Welcome everybody, I'm John Harkess with Coastal Orthopedics. We're going to spend the next 10 minutes or so talking about is knee replacement right for you. A little bit about me. I went to college at the University of Virginia, came back to Memphis for my medical residency and medical school. Went over the opposite coast for fellowship in total joint replacement, and I've been with Coastal Orthopedics as a joint specialist doing hip and knee replacements and some basic fracture care for the past 4 years or so, but loving the area. We're going to talk about arthritis of the knee today. Arthritis is not just a medical condition, it's a quality of life issue. It affects pain and function. Each person responds to that pain differently. You see certainly some people with terrible arthritis who have very little limitation in their life, and some people with very moderate arthritis who have significant trouble with their activities of daily living. Let's talk about what arthritis is. On our left here we have a normal knee. If you look at the knee, the thigh bone meets the shin bone, right? If you take a look, this white area here, it looks like the surface of a hard-boiled egg. That's cartilage. That's the smooth cushion covering that goes over the end of both the thigh bone and the shin bone. If we look here, you also have your meniscus and your ACL and your PCL, right? When you start to get a degenerative change of arthritis, you see a few things happen. One is that you start to lose your cartilage, or this cushion covering. If you look here, you start to see cracks there. When you have those cracks, you start to expose the underlying bone, all right? When bone rubs against bone, that's very painful, obviously. You also start to see bone spurs, and when you have this rough surface here, that starts to erode your meniscus, right? The end result is pain in a degenerative knee. In simpler terms, we think of a healthy knee as a well-oiled hinge. You have full motion and no pain. We think of an arthritic knee as a rusty old hinge with loss of lubrication and pain. If we take a look at your X-rays, and patients always ask me to explain this to them, here's a normal knee X-ray on your left side. We see the end of your thigh bone and the top of your shin bone. This bone out here is an accessory bone called your fibula. This little cloud right here, that's called your patella or kneecap, right? What you should see is space between your bones on a normal X-ray, even when you're standing. It looks like there's nothing in that space, but it's actually taken up by cartilage, or the smooth cushion covering over each of these bones. That space should typically be several millimeters thick. It should be equal across the length of the knee. If we take a look at an arthritic knee, we see the opposite here, right? We see your thigh bone and shin bone, instead of being well aligned, we see that they're now at an angle, or knock-knee type stance, and we see that you've lost all space between the bones. If you've lost that space, that means you've lost the cushioning that lives there. Bones are now rubbing against bones. This person has severe arthritis of the knee. So we talk about causes of arthritis. There are several. No person typically has arthritis just due to one thing, right? There's a wear and tear theory, or people who have more activity in their life are more likely to wear out their knee, right? There are genetic predispositions to arthritis, we know that. And then there are some specific causes. People who have trauma or injuries about the knee can later develop arthritis in the short, medium, and long term, right? We have inflammatory arthritis, things like rheumatoid arthritis or psoriatic arthritis. And then there are developmental issues where our bones don't form quite correctly and lead to problems down the road. As far as the prevalence of knee arthritis, it's significant in our community. So 12.5% of the population 45 years or older is affected by arthritis. All right, we all have friends and parents and siblings who do. 600,000 knee replacements are performed in the United States currently every year. By 2030, that estimate is going to quadruple. All right, if you look at who's getting arthritis, we have a higher incidence as you grow older, but we're starting to see it in younger and younger patients. The symptoms of arthritis, well, of course, knee pain, all right? You can have a chronic ache. People in the later phases of disease have night pain, which can even wake them up with sleep. It's made worse with weight bearing, going up and down stairs, especially arthritis underneath your kneecap. It's worse at the end of the day once you've had a chance to stir up inflammation within your knee. And it gets worse over time, all right? People talk about instability or giving way, swelling in their knee, as well as a noticeable limp. As far as limitations, we see the limitations progress over time. As far as how quickly they progress, we don't really know that, all right? That's kind of different with every person, but initially it starts to affect you with kind of high activity sports, golf, tennis, and eventually it affects everyday things like going to the Publix and taking vacations. Towards the end, you start having pain with sleeping, pain at rest, and getting up and down off the toilet. As far as non-operative treatments, we typically start with a wide variety of non-operative treatments for your knee arthritis. The first thing we recommend to you is activity modification, all right? Kneeling, squatting, lunging, jumping, we tell you to avoid those as much as possible because those are big generators of pain, all right, within reason. All right, we also talk about weight loss. Typically, people who lose 10 pounds feel like 50 pounds comes off of their knees and typically have excellent pain relief. As far as medical therapy, we talk about anti-inflammatories like Advil or Aleve. We have some prescription strength anti-inflammatories, which are COX-2 inhibitors. In the past, we've talked about glucosamine and chondroitin. There was initially some good evidence that might work. Later, some evidence came out showing probably doesn't, but it's still, you'll find a lot of people who swear by it. As far as physical therapy, people with arthritis tend to get stiff. Our interest as joint surgeons is to maintain the range of motion, so gentle stretching is an excellent thing. Then we also have injections. We have corticosteroid or anti-inflammatory type injections, cortisone, and we also have viscosupplementation or gel injections. As far as surgical options go, we have partial knee replacements and we have total knee replacements. A partial knee replacement, if we think of the knee, we divide it into three neighborhoods: the outside of your knee, the inside of your knee, and the area underneath your kneecap. Partial knee replacement only replaces one of those areas. Most typically, it's the inside of your knee. A total knee replacement replaces every surface where bone rubs against bone. We talk about when is the time right. That's one of the most common questions I get from patients in the office, and the answer really is it depends. All right. First thing we do when someone has arthritis is we take X-rays. All right. We look for the severity of the disease. If you look at this patient's knee, it's at a 45-degree angle. They've been rubbing bone against bone for years. All right. We also talk about mechanical symptoms. Are they giving way? Are they falling? All right. Next thing we consider is their health, all right? Do they have stable medical complications? Do they have, is their cardiologist willing to clear them for a surgery? Are they able to come off blood thinners? We need your BMI or a relationship of your height and weight to be less than 40, and we want your A1C level for diabetics to be below 7. We have these guidelines in place because research has shown that people with BMIs above 40 or poor diabetic management have a much greater risk of complications following surgery, which, although rare, can be significant in knee replacement. As far as quality of life, does your knee pain interfere with your activities of daily living? Are you missing out on hobbies or activities? Do you have pain which wakes you from sleep? It's all of these components that we think about. We would never treat someone just based on an X-ray. We would never treat someone just based on symptoms, but what I tell people is when your X-rays meet certain criteria and you're missing out on things that you want to do on a daily basis, and if you're a good candidate, then now's the right time for a knee replacement. You have to be ready for a knee replacement. A knee replacement is a big step. It requires a lot of work on your part, but in the end, the vast majority of people are incredibly happy with the result. Let's talk about surgery, all right? A lot of people think that we cut your whole knee out and put a whole new knee in, but in reality, the only part of an arthritic knee that is bad is right where those bones kiss each other, all right? So what we actually end up doing is just shaving a few millimeters off around the shin bone, placing this metal cap here, shaving a few millimeters off the top of the shin bone, placing this metal cap here, and then putting a piece of plastic in between them. You can't see the plastic on an X-ray, it's not dense enough, but it lives right in here, so now you're rubbing metal against plastic. We also put a plastic button on the back of your kneecap here so that everything rubbing against each other is now artificial. Success after a knee replacement depends on a bunch of things, all right? First is your surgeon, all right? We're lucky to have a lot of quality surgeons at Coastal Orthopedics. Preoperative education and preparation, that's one of the biggest things that we focus on at Coastal Orthopedics is getting you ready for the experience of knee replacement, all right? You really do have to be mentally and physically prepared to go through the experience. A knee replacement is no fun unless you have good pain control, so we focus on what we call multimodal pain control. It used to be in years past, the answer was more narcotic medicine. Now we approach pain from a myriad of different directions. We use anti-inflammatories and special nerve blocks and special pain relief that we inject into your knee. We also have taken great pains to optimize the hospital environment for your success, and we focus on post-operative care, right? The actual surgery of knee replacement typically only lasts 45 to 90 minutes. It's everything that comes in the weeks and months after that is the hard part, all right? We talk about preoperative education. First thing we do is make sure that your home is ready for you, that you're able to live off the first floor for an extended period of time possibly, that you have family there to help you, and that we set realistic goals and expectations. We let you know what to expect so that you're ready to go afterwards. We talk about multifaceted approach to pain control. We use a number of different things, from anti-inflammatories to steroids to special kinds of anesthesia like spinal anesthesia or femoral and sciatic nerve blocks. We use as much non-narcotic pain medicine as we can use, things like tramadol or Neurontin or Lyrica, in order to avoid making you sleepy or unable to participate in your therapy or making you nauseous. As far as the hospital environment, hospitals are full of sick people trying to get better, but in orthopedics, we're very much different. We're athletes training for the big game. So to have a culture like that, we almost have to isolate you and set up people who are kind of dedicated to that goal. We have an isolated orthopedic floor at Lakewood Ranch where the focus is on getting you up as quickly as possible, on twice daily physical therapy in a group setting and in an individual setting, and it's a really tried and true pathway that we've developed over many years. We talk about what makes for success in the short and medium term after a knee replacement. The first thing is early mobilization. We get you up and moving as quickly as possible. We have focused physical therapy. The goal of any therapy after knee replacement is to increase your strength and range of motion and also get you back to your everyday life, all right? When we send you home, we make sure that home works for you, okay? That you're able to get around and navigate and get back to your life as quickly as possible. As far as your recovery expectations, you're going to be out of bed on the day of your surgery. We're going to have you up and walking, going to the bathroom, all right? Again, we don't view you as a sick person. We view you as on the training program, all right? You should be home either the day of your surgery or within a day or two, depending on certain circumstances. Typically, you're on a walker for less than a week. After that, you progress to a cane or nothing at all. Driving at 4 weeks, typically, as long as you're off of pain medicine. Typically, you're returning to low-impact activities, office job, things like that, by 2 to 4 weeks. Typically, higher activities, golf, things like that, 6 to 12 weeks. Again, thank you for joining us today. I'm John Harkess with Coastal Orthopedics. If you have any questions, we're always happy to see you. We have numerous hip and knee specialists at Coastal, which are happy to field any questions you might have.